So anyways, we're going to explore that a little bit. We're going to get into this concept of mutually protected occlusion, okay? So this describes our masticatory system, basically how our teeth all come together, hit, and chew. There's many things that participate in this, right? We have the joints, we have the teeth themselves, we have muscles that allow the jaw to move around, right? We have ligaments that will limit the amount of movement we have. And then we have the teeth with different designs, different orientations, different root lengths, different number of roots. And we also have the teeth itself and all the different layers in there, right? Enamel, dentin, pulp tissue, cementum. And we also have the structures that hold the teeth in place, right? What we refer to as a periodontium. I know you guys have had your intro to perio class, right? You guys explored a little bit about gum tissue, things like that, right? Okay? All right. So we'll lead off with that question. Well, what's the ideal way in which our teeth should come together? And I'm going to quote a lot from this. This is a glossary of prosthodontic terms. It's just a bunch of dentists got together and said, okay, let's formalize some of these definitions, okay? So this idea of mutually protected occlusion is defined this way. An occlusal scheme in which the posterior teeth prevent excessive contact on the anterior teeth in maximum intercuspation, and the anterior teeth disengage the posterior teeth in all mandibular excursive movements. Okay, so it's a lot of words. Let's simplify this a little bit, because this is just like a word vomit, right? So the way I would simplify this is I would describe mutually protected occlusion as an occlusal scheme where really the back teeth or posterior teeth protect the front teeth, and then the anterior teeth protect the posterior teeth, right? Mutually protected. Two different things protect each other, okay? So let's ask this question. Well, how do the posterior teeth protect the anterior teeth? And when we go back to the definition, they'll say, well, the posterior teeth prevent excessive contact of anterior teeth in maximum intercuspation. Okay, so this term, maximum intercuspation, may be a new term for you, and let's kind of define it so we can start speaking like dentists. So a lot of these words, like you know what maximum means, you may know what intercuspation means, but some of these terms carry a very specific or narrow definition and meaning when you're talking to other dentists, okay? So let's define this. It's the complete intercuspation of the opposing teeth. It's kind of funny is they use the same word to define the word, right? So it's like, well, what's intercuspation? Well, it intercuspates, right? All right, so let's give it a little example, okay? So here's a cross-section of a set of teeth, right? And then you can see that we have the cusp tip interdigitating or really contacting in the fossa of the opposing tooth there, okay? And this is part of kind of normal occlusion or what we find in a normal occlusion. Cusp tip in some sort of depression, okay? And if you think about it, as you have more and more of these teeth lined up, it forms this interlocking that kind of stabilizes all the teeth together, right? So we have this cusp to fossa relationship that allows for the interlocking of these masticatory forces. And then we know that some cusp tips actually touch and engage the opposing tooth. So we can further kind of categorize this, and we'll have some cusps that are functional and some are non-functional, right? So in your basic understanding of dental anatomy, let's take a look at the lower molars. Which side, buccal or lingual, are functional cusps on the lower teeth? Buccal, okay. And how about the maxillary teeth? Lingual, right? Okay. So we'll go through this and just, you can kind of intuitively, or if you kind of can imagine your typodonts, just go, okay, which ones touch? And there's others that don't touch, okay? So that'll be just kind of automatic in your head at some point, okay? As we move to the front teeth, right, they're shaped a little differently, obviously. So we have the lingual surfaces of the maxillary teeth contacting the incisal edge of the lower, okay? So not hitting on a kind of fossa per se, but it still provides some additional stability to this occlusion, okay? Because you have some contacting point that it will rest in at the endpoint position, okay? So lingual surfaces, maxillary anterior teeth, incisal edge on the mandibular lower. So let's think about it. What is something you do pretty much every day? You're going to eat and you're going to chew. Okay, so that's a few times that your teeth come in contact with each other. Can you name other times or other activities that you do where your teeth end up touching? Sleep, because some people grind. Okay. What's something else that you do actually more times a day than actually chew? Talk. Okay. So if you were to kind of time how many actual, like the length of time that your teeth actually come together in chewing, it's actually a very small amount of time. On average, about 10 minutes a day, they're actually kind of contact, right? A lot of times you're just like talking to your friends in between bites. But swallowing is one of those things. Everybody pull up some saliva and swallow. Your teeth come together, right? Okay. So you actually swallow much more than you do the actual act of chewing, okay? So every time your teeth are coming together there. But yes, of course, sleeping, grinding, if you have those habits. So the idea is that every time you're doing this, your teeth are touching, and over a long period of time, guess what happens? The tooth structure kind of wears, right? And it kind of builds this landing pad, where now, if we were to take a cross-section, let me jump ahead. So this is an example of somebody's cast of their teeth. And if you look closely, you can see these little divots or wear patterns on the tooth surface, okay? So it's really ground in this like very stable endpoint position that your muscles kind of remember where to close your teeth so that they come together to this endpoint position, okay? So you can imagine that when you have all these teeth coming together, it fits together like this jigsaw puzzle where there's really only one position in which you have the most stable bite. And that's generally when all the cusp tips are in either a fossa or a wear facet or a mandibular or a marginal ridge that really holds things stable. Okay? So that's what we define as the maximum intercuspation position. Okay? You may also hear this term as MI or MIP, just as abbreviation, all mean the same thing. Okay? Maximum intercuspation, maximum intercuspal position. This is what we're trying to get at, is when you have all the teeth tightly joined together, interlocked together, almost like a puzzle piece, where there's one final endpoint position. And generally, that's very stable and predictable, because over time, you've gone to that position every single time, and then the teeth have worn together, so it's kind of milled in together. The other thing that happens is, since you've done it so many times throughout the day, throughout your lifetime, your muscle or your neuromuscular activity, you don't have to think about it. It's like subconscious, right? When you get to that end point, or how to get your teeth together, okay? So that's MIP. Questions about that? All right, so let's continue. So how do posterior teeth protect anterior teeth? The better question is, well, how are the posterior teeth designed to protect the anterior teeth? So let's look at a few differences here, okay? We'll start with the number of roots. How many roots do your maxillary molars have? 3. Okay. How many molar or roots does your mandibular molars have? 2, right? And then the remaining anterior teeth, we generally almost always have 1, right? So single-rooted incisor, single-rooted canine, okay? So think about also how those roots are positioned or oriented. So what do we know about the maxillary molar? Those teeth are flared, almost like a tripod, right? So a tripod is generally fairly stable, right? Okay, so we have greater number of roots. This also translates to a greater surface area of roots, right? And what do we know connects the root to the bone? What's that structure that forms that connection? PDL, which stands for periodontal ligament, right? So we have a shock absorber that kind of cushions the tooth as we use it and chew. So greater number of roots generally means greater surface area. Greater surface of PDL provides this shock absorbing effect, okay, or a cushioning effect. So that's good for us, okay? So here's some diagram. You know, we have PDL fibers that run in various directions. So there's horizontal group, the interradicular group, which means between the roots, oblique, so some at a different angle, apical. There's also some that aren't even listed on there. There's ones that wrap around, like circumferential, right? Okay. And then you haven't had radiology yet, but when we look at the X-ray here, the PDL space is going to be this thin kind of black line that surrounds each tooth, okay? Generally about 200 microns thick. So I know we haven't worked in microns much, but just to give you a reference point, the thickness of a human hair is about how many microns? Anybody know? Generally about 50 microns, okay? So our periodontal ligament width is about 4 strands of human hair kind of put together. So pretty thin, but at the same time, very strong and provides a very valuable functional feature in protecting our teeth, okay? All right, so we know the number of roots. Let's look at the orientation of the teeth when we compare back teeth compared to front teeth, right? So front teeth, how would you describe how they're oriented against each other? They're like at an angle, right? Versus our back teeth, they're lined up more or less right over each other. So you can load them in a direct vertical direction. Whereas the anterior teeth, if you load them, they also have a horizontal or lateral component to it, which means that it can get pushed out or kicked forward if you end up overloading it, okay? So the orientation of the teeth are different, okay? So we term this idea, right, axial loading. It's better to load the tooth along the long axis of the tooth, and then when the teeth are lined up so that the long axis are with each other, then that generally makes for a more ideal loading situation, okay? So again, looking back at our PDL, let's see what happens when we load it along the long axis. So the motion here is a bit exaggerated, right? We're going to load the tooth vertically, so straight down. So you can imagine when you're chewing, you have a piece of food between the upper and lower molars, and then you're going to load those teeth, okay? So when you chew there, guess what happens to the tooth? It gets a little bit depressed, right? What happens to the majority of those PDL fibers? They're going to stretch a bit, right? So when they stretch, we're going to term that those fibers are put in tension, okay? So that's important to understand. One, that it's in tension, and then two, that the PDL and bone always does better when it's put into tension stress versus compression stress, okay? If we look at compression, we're looking at the apical fibers, right? In this clinical scenario, the apical fibers that are compressed aren't as many, right? So we just have a small area that when you're loading has this more or less favorable loading under compression, okay? So we're maximizing kind of the utility of the PDL fibers because the majority of that is put in tension, which the body is better able to tolerate compared to compressive forces, okay? So that's a key principle to understand here. All right, so we have number of roots. We have the orientation of the teeth. Let's talk about the occlusal table as the last component here, okay? So when we look at our posterior teeth, they're much wider and larger, right? So how is that an advantage? Well, the wider your teeth are, the more occlusal contacts you have to be able to absorb some of these forces and transfer that down to your PDL, okay? Because the PDL are the best structure to take on and dissipate forces. We want to minimize forces on the enamel and dentin because we want to make sure that those don't wear or get overloaded. But the PDL is designed to stretch, right? Okay, so wider occlusal table is more beneficial. And then we can see if you were to sum up all the forces or the contact points where it hits the molar or premolar, you'll find that the sum or the vectors all sum up to go down the center of the tooth and load it down the long axis. So very similar principle. All these things are kind of connected to each other, right? Orientation of teeth is connected to their PDL because it loads it more favorably. Occlusal table, again, transfers all that along the long axis of the tooth, so it maximizes the use of the PDL. So even though we've categorized these things into 3 different things, it's like it's all wrapped up in one concept, okay? So wider is kind of better for us. And if we look at how our teeth are oriented, so let's pay attention just to the lower mandibular teeth, right? If we look at this cross-section here on the right side, you can see that those teeth are tipped a little bit in which direction? At least the crown part is tipped more lingually, right? And then if you look at the opposing tooth, the maxillary molars, they're tipped a little bit buccally, right? So that when they come together, they're more or less lined up, okay? So this gives you just a schematic of kind of the orientation of some of these teeth when we put them all together, right? So that's the, let's summarize this slide, or kind of this first section. So how do the posterior teeth protect anterior teeth? Well, a number of roots. Posterior teeth have 2 to 3 roots, which contrasts with single-rooted anterior teeth. The increased root surface allows for greater dissipation of forces through the periodontal ligament when loaded in the vertical direction. Number 2, orientation of the teeth. The posterior teeth are oriented vertically against each other, allowing for the force applied by the functional cusps to be directed down the long axis of the opposing tooth. This is contrasted by anterior teeth. They're generally oriented off axis from each other, okay? And then lastly, the occlusal table. The location of the contacts and the slight tilt of the teeth helps centralize the force through the long axis of the tooth. The wider occlusal table of the posterior teeth is ideal for the absorption and transfer of force to the root and underlying bone. Posterior teeth generally have more contacting points when compared to the anterior. Okay? All right, so let's do the reverse. How do anterior teeth protect posterior teeth? Right, is that the next part? Yes. Okay, so let's read what they said, right? Anterior teeth disengage the posterior teeth in all mandibular excursive movements, okay? So this term excursive, I'll just have you guys understand that as any movement away from your maximum intercuspation position, right? So think of maximum intercuspation as like your endpoint position or your home base, right? So if you put all your teeth together, right, that's your MIP. Any movements away from that is going to be an excursive movement. So what are the movements you can do? You can slide your jaw straight forward, right? You can slide it side to side and have your teeth in contact, right? So those are all excursive movements, okay? So the idea is the anterior teeth disengage the posterior teeth in all mandibular excursive movements. When we say disengage, what we're going to find, you can almost substitute this word separate, okay? So the back teeth will no longer be touching when the anterior teeth kind of are gliding off of each other, okay? So let's see an example of that. So here's a video, and you're going to see 2 things. One, this patient moving their jaw to the side, and then moving their jaw straight forward, okay? So the first motion we're going to call a lateral excursive movement, and then the other we're going to call protrusive, okay, going forward. And then pay attention to the space that you see on the posterior teeth here, okay? Okay, so that was to the side and forward, right? So did you see which teeth remained in contact throughout that whole motion? The anterior tooth. Which anterior tooth in the lateral motion? Should we play it again? Let's play it again real quick. So as you go to the side, which teeth are in contact? Canine mostly. And forward, it's our incisors, right? Okay? So let's stick to the lateral motion first. Let's just focus on that. When we move our jaw to the side and we have only the canines touching and causing the posterior teeth to separate, we have this term canine guidance, okay? It discludes or disengages or separates the back teeth, okay? So pick whatever word you want, but that's the principle, okay? The canines separate the back teeth when we're gliding laterally or to the side, okay? The other principle is we didn't have a shot of the contralateral side, right, because of the view of the camera, but if we're to look at the simulation, it not only separates the posterior teeth on that particular side, but also the opposite side as well, right? So we'll see these motions and look at both of the posterior teeth. We're going to see as that patient goes in this canine guidance that both of the back teeth don't touch. Okay, so that's that principle, is that it separates the back teeth bilaterally, okay? So that's the key feature for what we call canine guidance, okay? So a very important term that you're going to hear over and over again as we get in the clinic is a patient in canine guidance. So you got to know what that means, and you got to evaluate the patient to see if they are in this clinical kind of representation. Okay, so what is it about the anterior teeth, or how are they designed that they are protective of the back teeth, okay? So one, let's talk about the canine, okay? What do we know about the canine and the length of the root? It's the longest rooted tooth that we have in our mouth, okay? So when all the anterior teeth are examined, it becomes apparent that the canines are best suited to accept horizontal forces that occur during eccentric movements. So eccentric, you can also think, here's the thing about dentistry, we can't stick to like consistent terms. We have all these terms that kind of mean the same thing. So what else have you heard? Eccentric, lateral, excursive, they all represent kind of the same thing, okay? So if you come across this, it means just a movement away from this MIP position. Okay, let's get back into it. They have the longest and largest root, and therefore the best crown to root ratio, right? They are also surrounded by dense, compact bone, which tolerates the forces better than the medullary bone or cancellous bone found around posterior teeth, okay? So let's kind of re-examine this tension compression kind of idea or length of the root. When we look at our posterior teeth, right, when we're loading it along the long axis, we said that compression was really only on the apical portion of those fibers there. But the majority of the rest of the PDL fibers are being stretched and put into tension, right? You guys remember that? Okay. Let's look at it when we load this tooth in a different direction. So instead of pushing straight down, now we're loading it side to side, right? So you can imagine as we're moving our teeth laterally, and if our teeth are in contact, it's no longer just a vertical force pushing the tooth straight down. We're now tipping the tooth or kind of knocking it to the side, right? So you see those arrows on the occlusal table? That's what it's sort of trying to signify, is that we're pushing these teeth kind of off axis, okay? So now instead of just the apical portion that's put under compression, now you have a greater number of PDL fibers under compression, okay? So in theory, less favorable, right? So if we're going to have this type of loading, and we know at some point some tooth needs to be loaded laterally, right? If your teeth are going to the side, you have to have something touch. But we're saying the ideal tooth to take on that lateral force is the canine. And it's a canine because it's got the longest root, okay? So you can think of it as, let's say you dug up or put a big wooden stick into the dirt, okay? And you load it and you push on it. If that stick is buried like 10 feet down in the ground, how much more force is that going to take to move that than if it was buried like 10 centimeters in the ground? It takes a lot more, right? So the principle is the longer rooted tooth, it's able to withstand those horizontal forces a little bit better just because of the anatomy of that tooth, okay? So the canine is most adept at absorbing those lateral forces. So even though the molars may have a greater surface level of PDL fibers, it's the length of the root that really gives the canine the big advantage in this particular scenario. Okay? So longest root, yes?
Is it because there's more PDL fibers, or just, can you explain more in connection to the fibers?
Yeah, I would say it's just think of that example. If you have a stick in dirt, right? And if you bury that stick very deep in the ground, right? Think of all the dirt that you got to move for that to even like bend a little bit. Versus if it's pretty shallow in the dirt, it doesn't resist that movement as much because the mechanical advantage of going deeper is pretty significant, okay? So it becomes kind of a physics or a mechanics kind of rationale, okay? That's the best way, I think, to understand it or explain it. Okay, they also mentioned the quality of bone, right? There's this concept of cortical bone or compact bone, right? Very dense. So if you look at that middle image, what do you notice about the layer of bone on the outside of that mandible? It's really dense, right? There's hardly any radiolucent areas. It's all bright white. So that means that bone is very thick and very dense and very strong, okay? On the inside is more what we call cancellous bone, right? Or compact bone, I think is what, or sorry, what do they term it in the previous slide? Spongy bone, right? It looks like a sponge. It's got all these medullary spaces, okay? So the anterior teeth, particularly the canine, is surrounded by more compact bone where just based on our anatomy, our posterior teeth are more embedded in the softer, what we call quote-unquote softer bone, okay? Question? Yes, yeah. Maxillary teeth, especially the maxillary posterior teeth, is where we actually find the softest quality of bone, okay? So one of the things you may not appreciate at this point, but you probably will once you get in the clinic and start doing some more, let's say, extractions, is that you'll find that bone is actually dynamic and it's able to be stretched. Like we think of bone, it's like, oh, it's just hard. You can't really stretch it, right? But in reality, bone has this dynamic feeling to it where over time, that's how you extract a tooth, right? You're gently expanding the socket wider and wider, okay? So the more medullary or spongy bone you have, it has this kind of ability to kind of be moved and rock a bit, whereas dense cortical bone is going to be stiffer and not allow for as much movement, okay? All right, so longest root, and it's in this kind of harder bone, okay? So a couple advantages there. All right. Location. So let's think about the location relative to the hinge axis, okay? So here's a diagram of a nutcracker, okay? If you were to crack a nut, do you want that nut to be closer to the hinge or further away of the hinge? Closer, and why is that? Yeah, the closer you are to that hinge, the more force that you can apply to that nut, okay? So same principle with teeth, right? If you were to try to crack a nut with your teeth, you're going to put in the front, you're going to put in the back. You're going to put in the back, right? So if we're moving, instead of the back teeth touching and being loaded in a horizontal manner, we're now telling, or we're asking the canine, all right, you do all the heavy lifting in lateral, you take on the brunt of those horizontal forces, and the canine is much further away from the hinge than the molars, then we're going to have a mechanical advantage in the sense that there's probably less stress on that canine because it's further away from that hinge axis, right? So think about where's our hinge axis in our masticatory system. If you were to draw a line between what two structures would represent the hinge axis. Our joint, right? What we call the temporal mandibular joint. So we'll have a slide on that a little bit later, but that's the axis in which things rotate and open, okay? So through our condyles, all right? Okay, so mechanical advantage with moving the contact point more anteriorly because it's now further away from the hinge axis. So just think of this nutcracker example. The further away you are from the hinge, the less force that gets applied, okay? When it comes to biomechanics, we'll call the jaw, it's actually considered a class 3 lever system, okay? So a class 1 lever system is like a teeter-totter, right? You ever play with that in the playground where you go up and down, right? Class 2 lever system is kind of like a wheelbarrow, right? If you ever picked up a wheelbarrow, right, you have the little handles. So that's the effort, right? You got to pull up. The load is all the stuff in the barrel, right? So it's that green arrow. And the fulcrum is the wheels in the front that you're kind of pivoting off of, okay? And then the class 3 lever is our jaw. So we have the fulcrum, which is our joint, okay? The effort is where our muscles are, and we're going to get into this where our masseters sit, where our medial pterygoids sit, and the load is going to be anterior to that, okay? So the examples of a class 3 lever in real life is going to be like a fishing pole, okay? Where you have the fish at the tail end or the end. The effort is going to be in the bend in that fishing pole, and the fulcrum point is where you're holding. All this to say, not that important, just know that's a class 3 lever system, okay? If we don't have canine guidance, right, we're saying that we want the canines to separate the back teeth, okay? Let's paint a scenario in which that doesn't happen. So we're saying the canine guidance is the ideal because it separates the back teeth. The canines take on the lateral loading, and that's preferable because it's the longest route. It moves it away from the hinge axis. It decreases the force there. This is a situation in which the contact is actually shared amongst multiple teeth. So let's play this video as we go to the side. We're going to see some of the premolars are also touching in that lateral movement. So when you have more than just the canine touching in that lateral movement, we're going to term this group function, okay? So that carries the kind of connotation or the definition of multiple teeth coming in contact in a lateral motion. And then just like we explained with canine guidance, okay, let me jump back here. Let's read the definition. Multiple contact relations between the maxillary and mandibular teeth in lateral movements on the working side, whereby simultaneous contact of several teeth act as a group to distribute occlusal forces. Okay. If you were to summarize it, you would say, well, if canine guidance is just the canines touching in lateral, group function is actually multiple teeth, more than one tooth touching when you go to this side. It doesn't specify which teeth. It kind of leaves it as a generic kind of thing. And when we talk in dentistry, we kind of do it that way too. It's like, well, which teeth? You know, you can like then spell out, oh, it's the second premolar and first molar that touch or whatever. But we kind of just have this general definition. Group function really is just not canine guidance, right? It's not just the canine, it's actually other teeth. Let's also define working side, right? Because this is a term you haven't seen before. And it's a pretty simple definition. So the working side is the side that the mandible moves towards, right? So in this video or this picture, if we're looking at the patient, right? The patient's, which side is that mandible moving in terms of relative to the patient? The patient's jaw is moving to the patient's left side, right? In that video. So that would be termed a left working movement. So basically the side that the jaw moves towards is the working side. That's the definition, okay? So group function, just like this diagram shows, it's multiple teeth contacting when you move laterally. If we were to look at this patient's opposite side, what you would find is that the back teeth here are separated. So we're only talking about the working side that you have multiple contacts touching, okay? If you find something else touching on this side, we would call that an interference. We're going to save a lot of those details for the third lecture. But for now, what I want you to understand is group function, when you have multiple teeth contacting, we're only referring to those teeth contacting on the working side, or the ones that we would consider or take into consideration, okay? And the opposite side of those posterior teeth, the contralateral side, shouldn't have anything touching in that group function motion. So that's the location. We move anteriorly. That makes it more favorable, right? So if we just isolate the canine, we're going to say, okay, only the canine's touching. That's more favorable than a group function situation, because group function, you have multiple posterior teeth touching as well, and those posterior teeth get lateral loading, which we're saying is not as favorable, okay? All right, let's talk about muscles. Here's the last reason why the anterior teeth are protective of the back teeth. So our back teeth, we can put a lot more force and load on there. And just as a simple experiment, right? So put all your teeth together and squeeze as hard as you can, okay? Now protrude your jaw forward so you're only touching on the front teeth and squeeze there, right? What do you notice about the amount of force that you can apply onto those teeth? Much less, right? So what's going on there? How do you explain why you can't put as much force on those front teeth as your back teeth? There's probably a few different explanations. Anyone want to give it a shot? Yeah. Surface area is smaller, okay, so you can't kind of occlude or, yeah. Anything else? Yeah, so similar, yeah, like we said, a lot of these principles are overlapping, so the further away, the less force that gets applied, okay? And yeah, so you would think too, look at the orientation of some of those elevator muscles, so where the load is, right? That nut that's in there is kind of directed right over where the muscles are, so that's an area that you can maximize force, whereas if you had the muscles contracting further away from that point of contact, you can't squeeze as hard, okay? Another reason here is that there's something about our neuromuscular system that when we have feedback to stress or loading on the front teeth, our muscles tend to kind of relax or quiet down a bit. They're not able to exert as much force when our anterior teeth are contacting because of just that neuromuscular feedback, okay? Do we have a great reason why? I'm sure we can come up with that, but the clinical studies that we've done, right? So one of the ways in which you can study this is if you do sort of just measure and put kind of electrodes on your masseter, let's say, right? And you measure kind of contractual forces, and then you told the patient to bite in the back and then bite in the front, we could actually quantitatively measure how much less that masseter squeezes, okay? So there's something about that feedback system that starts to turn off some of these muscles when it's the anterior teeth that are touching, okay? So that also is a protective measure that helps our back teeth from getting overloaded, is because we put pressure on the front and the muscles kind of quiet down and don't fire as strongly, okay? Good with that principle? Okay, so let's expand on this, right? How do anterior teeth protect posterior teeth? Well, we said that the canine provides disclusion in lateral movements. Remember, we were just focusing on side to side. Let's take a look at what happens when you go straight forward in this protrusive movement, right? If we go back to that video, in both scenarios, what do we see touching when we glide straight forward? Which teeth separates the back teeth in straight protrusive? Our incisors. So let's take a look here. So we'll go lateral first. Okay, canines separate, and we go straight forward. Okay, so our central incisors in that particular case separate the back teeth. Okay, and even in the other video, we also saw the same thing. So let's play that real quick. Right, lateral, so that's group function because multiple teeth touch. Straightforward, the incisors, okay? All right, so let's finish this part out. So we'll distinguish between protrusive and lateral now. So in our protrusive movements, we'll find that the incisors tend to separate the teeth, okay? Here's a problem with a lot of your textbooks. They almost always have these lines or marks, so representing the canines also being protective and protrusive. In reality, and maybe we can do this as a group and examine each other's bite, but I'd be surprised if we found somebody here that as you moved your jaw forward, that your canines also help and separate the teeth. It's almost always just the incisors, but in multiple textbooks, they always have these diagrams that show the canines participating in protrusive as well, okay? So let's explain these lines here, right? These lines just demonstrate or depict the movement or the contacting teeth as you slide in these movements, okay? So if we look at this slide, and let's put the black dots here. So this is your starting point. When your upper and lower teeth are together in MIP, this is where your lower incisors are starting from and touching. And if we said slide your teeth forward, that lower incisor is going to glide off of this path as you go to, until you get to that edge-to-edge position, okay? And then lateral is if you move your jaw to the side, so only the canine will have a lateral intrusive movement on one on each side, okay? So my point is this protrusive pathway on the canine, it's rare that we actually see that in being protective and protrusive. So I want to throw this slide in to kind of reemphasize the point that the canines are the main ones that provide disclusion and lateral intrusive movements when we're in canine guidance. And it's the incisors that do the heavy lifting when we're in protrusive movements. So why don't you do this? Pair up, look at somebody in your table, and have them start in MIP, have them slide your jaw forward, and keep an eye on the canines and see if anybody's canines assist in discluding your back teeth, okay? All right, so let's move on, okay? So we have this, we have a better understanding of mutually protected occlusion, right? Back teeth protect front teeth protect back teeth, okay? It all kind of works in harmony. What happens when one of those principles is violated, okay? Meaning, or not meaning, but one of the things we term this situation is occlusal trauma, okay? So it's trauma to the periodontium from functional or parafunctional forces causing damage to the attachment apparatus of the periodontium by exceeding its adaptive and reparative capacity. It may be self-limiting or progressive, okay? The part I want to focus on is exceeding the adaptive reparative capacity of the periodontium, okay? Let's unpack this a little bit. Let's first define a few things. What is the periodontium? Just in general, the periodontium represents all the things that support the tooth, right? So the components of our tooth are what? What are our layers of the tooth? The outer layer is, the inner layer is, and if you go deep into that dentin, we'll hit the, okay, and then what is the outer layer of that root surface? Cementum, right? Okay, so the periodontium kind of are all the things that kind of surround that tooth. So the tissue, right, the gingiva, cementum, I guess you can argue either way, right? So that's on there twice. But what inserts into the cementum? The periodontal ligament, and then the other side that the ligament attaches to is what? Bone, okay? So the tissues of the periodontium are the things that support the tooth, okay? When we have a situation where we're violated this mutually protected occlusion, what we tend to get is overloading or exceeding the adaptive capacity of that periodontium, okay? You could literally overload that system, okay? And we're going to term that occlusal trauma, right? So when we look at a normal occlusion or this mutually protected occlusion, we're saying that the back teeth help protect the front teeth because it takes on the majority of the load in maximum intercuspation. So when the patient bites down and comes together and clenches, all the teeth touch, right? So this photo is depicting all the points of contact that you have tooth to tooth, okay? You get these marks when you have this biting paper. So if you've been in a dental office and you've seen some procedures, you'll see the dentists oftentimes check their bite. And what they do is put in a piece of paper between their teeth and have them close together. And the points of contact get transferred from that paper onto the teeth. So if you look at photos of people's teeth when they all come together, you'll see a well-distributed pattern of marks on back and front teeth. The back teeth, we know, do the heavy lifting, right? They absorb a lot of the occlusal forces when your teeth come together, okay? So that's normal. What we see in what a scenario, because let's paint a scenario in which that principle gets violated, where we have an equal or a well-distributed contact points, Okay? So what you guys are doing right now is in sim is operative, right? What are you guys learning how to do? Class 2, where you're drilling out decayed tooth, and then what are you doing after that? You're restoring, and the idea is you're restoring it back to the form and function that it used to have, okay? So when you're restoring that tooth and building that height of that composite, right, how do we know how tall to make, let's say, the marginal ridge? What's the parameter that we're going to be checking for to see if it's too tall or too low? The marginal ridge next to it, sure. But what else is kind of the definitive thing that you ultimately need to check at the end of the day? Occlusion, which is where the opposing tooth is going to contact that restoration, okay? So imagine a scenario in which you built your restoration and composite way too high. What do you think is going to happen? Right? Where do you anticipate the bite marking if you were to check their occlusion? On the opposite cusp plus on your restoration. And do you anticipate other marks on other teeth? Why not? Right. Okay. Does everybody understand that? Do you expect other marks on other teeth if the composite restoration that you just put in is too tall? No. Okay, and hopefully everybody can understand why. Because your tooth, your opposing tooth is hitting that tooth first, and it's preventing the remaining teeth from touching, okay? What do you think is going to happen if you didn't adjust that bite or that occlusion and you left that tooth being the only one that comes into contact? You're going to get into occlusal trauma, right? We've exceeded the capacity that that one PDL has to absorb all the force, right? Instead of having the force distributed amongst all the teeth, you've concentrated it on one tooth only. It's going to cause some discomfort. It's going to cause occlusal trauma. So this is a classic example of occlusal trauma, right? A new restoration being left in what we term, and you may want to write this down, I don't think I have a slide on it, hyperocclusion. So what do we mean by hyperocclusion? When the restoration or the occlusion is too tall on that particular tooth, okay? Conversely, what would be hypoocclusion? If that restoration was made way too low and that tooth never gets the opposing tooth to touch it, okay? So you would have one less contact in the whole arch if you left that restoration in hypoocclusion, okay? So occlusal trauma occurs, this is a classic example of occlusal trauma occurring is when a restoration is left in hyperocclusion, okay? You're overloading that tooth. It wasn't designed to take on the force of all the teeth. It's meant to be shared amongst multiple teeth, okay? Right, so how do we fix that, right? Answer is pretty simple when it's a single tooth restoration. What's our solution to relieving that occlusal trauma on that particular tooth? Grind it down so that it's not in hyperocclusion. Question? Okay, so hypoocclusion may not cause discomfort, right? It just means that the other teeth take on a little bit more of the load. So if we go back to this image, right, look at how many marks there are. If you took away one tooth, do you think that the other tooth will be overloaded? Okay, enough to cause pain? Probably not, right? So generically, it's like if you just lost one contact in this whole system, it's probably not a big deal, right? You still have plenty of other posterior teeth to help protect. There will be a limit once you, let's say, take out all the molars. You may get in a situation where you'll start to feel something going on, okay? So it's going to be different based on the clinical present, and everybody's a little different. There's a tiny little old lady with the small muscles or a big guy that's a grinder, okay? So hypoocclusion in itself may not be detrimental. You kind of have to look at the big picture and see what else is going on. Question? So one of the things that we'll talk about is this idea of occlusal trauma. It can be self-limiting in the sense that even if a tooth is under occlusal trauma, there's things with our bite that kind of tend to correct itself. One of the mechanisms in which a hypoocclusion would be corrected is you get supereruption or drifting of the opposing tooth and then it comes down. Supraeruption, which means that the tooth continues to erupt until it finds a contact point. Okay? So generally, hypoocclusion is generally not as detrimental or detrimental at all compared to a hyperocclusion. All right, so we talked periodontium. This is what a normal distribution we want the bite to look like, right? This is a scenario in which that principle of mutually protected occlusion gets violated. We have excessive force on that one tooth, right? More than that PDL can take, okay? And then the solution to that is, well, how do you decrease the force on that filling that's too high? Adjust it so it's not high, right? Pretty straightforward. Okay, here's another classic example of the periodontium being overloaded, okay, and then causing problems. So let's take a look at these three clinical scenarios, and let's start pointing out some commonalities between these three things, okay? All right, so let's break this down a bit, okay? This is another classic scenario in which we would see occlusal trauma. So the lack of what we call posterior support. So this term will be kind of embedded in your brain too, okay? Right? Posterior support means the posterior teeth are removed and it's no longer providing that protective elements that we had described in the very first part of this lecture, right? We said the posterior teeth are great in absorbing vertical forces to protect the anterior teeth, right? So if those posterior teeth are gone, guess what's happening to the anterior teeth? It's taking on all the occlusal forces. And what do we know about the orientation of the anterior teeth? Yeah, they're not lined up along the long axis. They're at an angle, perfect, right? So what do you think happens if you were to load things in a direction where it's not along the long axis to those front teeth? Yeah, they're going to drift, right? They're going to move out of the way because they're getting overloaded. What do you think happens as the teeth flare forward? What do you anticipate seeing between the teeth as they drift apart? Space, okay? So look at those examples where you see space between the teeth. Let's back it up, right? The first scenario, you see the space between the lateral and canine in that side shot, right? You can see multiple spaces in the middle case, right, between the incisors. What do you notice about that third case? What do you see on the central incisors there? You don't see really space between the teeth, right? And why not? Because they filled it with composite, okay? So there was space at some point. So this clinical example still fits in this scenario where the front teeth are getting overloaded, but they've kind of just masked the space with restorative material. But in reality, there's space that formed between the teeth, okay? So can you guys see the progression of this trauma as back teeth are lost, right? The back teeth no longer protect the front teeth. As a result of that, the front teeth are going to be damaged. And when we say damage, one of the ways it manifests itself is movement of those teeth and then formation of a diastema is the term we use to describe gaps between the teeth. Diastema, we'll have that in the slide. And that's one of the signs of occlusal trauma, okay? Yeah, right here. The pathologic migration can lead to diastemas forming and or supereruption of teeth. And when we say supereruption, we'll define that as drifting of the teeth either downward or upward, basically towards the coronal or incisal direction. Okay, so going away from the bone or gum tissue. Okay, so one of the other things that we can see when front teeth are being traumatized, and I know you haven't had radiology yet, but when we look at these x-rays, remember that there's one photo we pointed out, that little thin area, we call it the PDL. Well, when front teeth get overloaded, that PDL space actually gets wider. and it gets wide enough to the point where we can detect that on the x-ray, and it's going to look noticeably different than the adjacent teeth, okay? So another sign of occlusal trauma due to the lack of posterior support is widening of the periodontal ligament on the anterior teeth that can be seen upon radiographic examination. So here are some examples, and I think that middle one is probably the clearest, where that space around each of the teeth is significantly wider than what you would see in a normal kind of scenario, okay? So another, and let me point this out, you have that second photo probably is a good comparison. I would say that tooth number 9 here and tooth number 10 exhibit signs of widening of the PDL, whereas tooth number 8 here looks more normal, okay? So that's how you kind of want to, you got to have a baseline of what's normal before you can say what looks wide. Question? Or are you just stretching?
Oh, me?
Stretching? Okay. Yeah. I would say that central incisor is a little bit wider. Yeah. Yeah. So. Okay. But in principle, you get widening of that periodontal ligament space because it's getting stretched and overloaded, right? Beyond its adaptive or reparative capacity is how we describe it. Okay. So again, another scenario, right? Loss of posterior support. And what we see here from a sagittal view is the flaring of the teeth. Remember we talked about the teeth getting overloaded and getting pushed forward. You get diastema. You also see this, where the angle that Catherine described, right, gets more exaggerated because it's getting pushed. Okay? And then with that, you also get super eruption, or the downward drift of that maxillary central incisors. So if we were to look, if we were to rewind what she looked like before all those back teeth were taken out, her teeth were probably a little bit more apical, but over time they've drifted down, okay? Okay, so we visited 2 scenarios that are very typical of occlusal trauma, right? The first one was what? What was the first classic example of occlusal trauma? Hyperocclusion. Number 2, how would you describe the second scenario? When all the back teeth are removed, or a majority of the back teeth are removed, we call that the loss of what? Posterior support, right? Okay, the third one that we classically see, right, so same kind of manifestation, right? Diastemas, supereruption, uneven occlusal plane, is when the periodontal support has been compromised, right? So you guys have learned a little bit about this in your perio class with Dr. Malik, right? Periodontitis, does that sound familiar? How would somebody here describe what periodontitis is? Loss of bone is a very, yeah. If you're going to explain to a patient, you don't need to get into fancy details. You say, you have bone loss. The supporting bone around the teeth has been lost, okay? We would then describe, okay, as dentists we know it's due to what? Bacteria as an etiology. And what else needs to happen for bone to be lost besides the presence of bacteria? Anybody? Yeah, okay, so inflammation is one part of our immune response. But really, yeah, so inflammation first, but it's our immune response where we get collagenase and osteoclastic activity that breaks down the bone, right? So there's always 2 things that contribute to periodontal disease. Always plaque as a primary etiology, but it needs a host that's susceptible that will elicit a immune response for the breakdown of bone, okay? All right, so this patient probably has periodontitis, right? We can visually see that. What's the biggest clue there? The bone is not as tall as it should be in a normal, healthy, let's say 18-year-old, right? Where would the bone be generally in a healthy 18-year-old? What landmark would you kind of look at to kind of assess a normal bone level? CJ. And that bone is maybe a millimeter or a couple millimeters just apical to the CJ is a normal bone level, okay? So you can see some of these images clearly show, especially that upper left side, a lot of loss of that periodontal support. So what do you think happens to these teeth when you've lost bone around there? Besides bone, what's the bone connected to? PDL. If you have less PDL there, what do you think? You'll lose that cushioning effect of those teeth, right? So those posterior teeth, even though they're present, they're not as helpful and they're not as protective, right? You see how that works? So if the posterior teeth aren't as protective, it's kind of like in the similar boat of loss of posterior support, right? The back teeth are no longer protecting the front teeth, and then you can get overloading of the teeth in general, okay? And then you get some of the similar signs and symptoms that we saw earlier, widening the PDL, diastemas forming, flaring of teeth, okay? So those are a few classic examples of occlusal trauma, okay? If we were going to categorize occlusal trauma, some dentists back in the day, they've decided they want to classify occlusal trauma into two different categories, okay? Primary and secondary occlusal trauma. And I'll just jump to kind of the key slide here. The distinguishing feature between primary and secondary occlusal trauma is the level of periodontal support, okay? So basically, the first examples that we had, a high filling and the removal of back teeth, well, let's back it up. Let's start with secondary occlusal trauma first, okay? So something is what we consider secondary occlusal trauma if the bony support around the teeth has been lost. So you think about like a tree, right? If you dig up all the dirt around the tree and then you go shake the tree, it's going to feel loose, right? Why does the tree feel loose? It's because you dug up all the dirt around it and there's not as much support in that root structure, right? So that's what secondary occlusal trauma is. It doesn't matter if the force that you're applying to it is excessive or normal. That's sort of irrelevant. We're just looking at the presence of bone loss or attachment loss, however you want to phrase it, and it's that example of digging up dirt around a tree. So if that is present and you can identify bone loss around the teeth, and then you have occlusal trauma, we're going to consider that secondary occlusal trauma, okay? So that most recent example with all the bone loss, that's a classic secondary occlusal trauma scenario. If we go back a bit, and let's define primary occlusal trauma. Well, this is if the bone levels are perfect, but you have excessive force and you're overloading teeth, okay? So those first two scenarios, right, when you have a tooth that has hyperocclusion, and we've evaluated their bone levels to be normal, and they're subjected to excessive force, that's primary occlusal trauma, okay? Same with the second scenario. If we were to look at their bone and we find all the bone levels are perfect, but all the back teeth are taken away, and the front teeth are now being overloaded, that's another example of primary occlusal trauma. I'll get to you in one sec. So the caveat, or the thing that's really critical for you to understand and probably want to write down is, in order for you to distinguish between primary and secondary occlusal trauma, you have to have an evaluation of the condition of the periodontium. If you don't know the condition of the periodontium, you cannot distinguish between primary and secondary occlusal trauma. Because the whole point, or the distinguishing feature, and I'll have this up again, is the level of periodontal support. Secondary occlusal trauma has decreased periodontal support. Primary occlusal trauma has normal periodontal support. One of the questions I know I'm probably going to get is, well, what if there's a case where the teeth are being excessively loaded and there's decreased periodontal support? So it kind of fits in both categories, right? At that point, we would still consider it secondary occlusal trauma because it still fulfills that criteria of decreased periodontal support. Okay? Question in the front. Oh, how did I know that's what you're going to ask? Okay. So yeah, let's back it up. Let's go back to this scenario and let's paint a picture. And we don't have the x-rays for this particular patient, okay? But we would say that this patient shows signs and symptoms of occlusal trauma, okay? So this patient has the loss of posterior support, okay? We would say that the anterior teeth are being overloaded, and we have a suspicion they're being overloaded because of what clinical feature? What would you say is one sign that this is being overloaded? Flaring the teeth, supereruption, okay? If I were to ask you, without giving you any more information, is this patient undergoing primary or secondary occlusal trauma, how would you answer that? Without any other information, could you tell whether this is primary or secondary? No, and why not? I haven't given you any information to suggest if they've lost periodontal support or not. No. Can a tooth be mobile or move with full periodontal support? The answer is yes, to some degree. Think about a widened PDL, right? How thick did we say the PDL is? 200 microns, about the equivalent of 4 strands of hair. Imagine that PDL is now widened. So let's say we've tripled or quadrupled the width of that PDL. How much can you move that tooth now? Almost to a millimeter, right? 0.8 millimeters, let's say. So you can have movements of that tooth, right? And it may drift a bit, but still have the full periodontal or no bone loss around it yet. Okay? You see how that would work if you have a widened PDL, right? There's space now for that to move. Okay? Question. I think it's all kind of connected, right? Because if you have bone loss, then you know you have PDL loss, right? Because the bone is connected to PDL. So I just think of it as like just the bone. Yeah, you can simplify it, just how much bone is holding on to that tooth, right? Just like dirt around a tree. Like you dig it up, it kind of doesn't matter what you call it. Yeah. Yeah, it's a great question. So secondary occlusal trauma will always be in a patient that has periodontitis. Perfect. That's another way you can explain it. How do we treat it? So we've kind of talked about this, right? If you have heavy or excessive forces, how can we rectify that situation? Well, it kind of depends on the source of it, right? If the heavy occlusal force is due to hyperocclusion, what do you do to the hyperocclusion? You get rid of it by adjusting the tooth. If you have overloading of those front teeth because of lack of posterior support, what can you do? Add posterior support. And you're going to learn in your future classes ways in which you can add posterior support. So for those of you who have some sort of dental knowledge background, what are some ways in which we can replace missing teeth? Dental implants. So this is a photo of a dental implant where you've restored posterior support. What's another way? Removable partial denture, where we have a prosthetic device that comes in and out that replaces. And if you have teeth in strategic places, you can have what we would call a bridge or a fixed partial denture, okay? So we have ways to correct the loss of posterior support, okay? How would you correct for, okay, here's another principle that I want you to know. We kind of got into this discussion about if we lost, let's say, one of those teeth that is in hyperocclusion, or you've removed a tooth or two, is there a tipping point where we start to see this occlusal trauma? So people have done studies, right? They've taken people which are what they've termed a shortened dental arch. So from second premolar to second premolar, and they've followed them over a long period of time, a few studies, 15 years plus, and then they, as they follow them, they see if they start to suffer from some periodontal disease, or they have discomfort, or they ask a bunch of quality of life questions, right? Because at the end of the day, we're treating a patient, and if a patient has like 2 teeth removed, we as dentists go, oh, we'd like to fill that and kind of complete your full arch of teeth. Because it's like, that's the world we live in, and we like to see things nicely filled out. But there's times where the patient has no desire to replace a missing tooth or two, because functionally, when it comes to their quality of life, they don't notice that it's missing. They're able to eat what they want. They're able to speak normally. They're not having pain. Some choose not to replace missing teeth, right? So you can have some patients at second premolar, and we consider that a shortened dental arch. Long term, patients tend to do fine with that many posterior teeth, just the premolars, okay? Of course, every patient will be a little bit different, but there is some data in the science that we've tracked a population of patients with a shortened dental arch, and many of them do okay without suffering symptoms, nor do their quality of life is drastically kind of diminished, okay? So that's kind of that principle I want to point out, okay? How do you treat secondary occlusal trauma, right? We talked about that, that's the loss of periodontal support or a patient that has periodontitis. One of the ways in which we can kind of help those loose teeth out is we splint them together. We tie them together. There's different ways to do that. You can do it with composite or a little wire. Some of you have this wire when you've done orthodontics, right? It's a similar principle. You bond that together, and it kind of braces all the teeth together so they function as one unit. So you've tied some of these loose teeth to teeth that have better periodontal support, and that kind of alleviates some of the symptoms that they may have, okay? So maybe they're not as mobile, because now when you load it, all the teeth need to move instead of just the one, okay? It's not a permanent solution in the sense if you ever remove the splint, you're still going to have this trauma, but it's one way to kind of mitigate kind of the trauma. You do, I was going to point out, there are some compromises to this though. The compromises to splinting are twofold. One is aesthetics, and two is hygiene, right? If you think about a patient that has undergone periodontal disease, what's something they probably didn't do a very good job of? Brushing their teeth, keeping plaque away from the teeth. Now you're going to introduce a splint that gets in the way of what? Flossing, right? So some of these patients that you're treating, you really have to focus on the oral hygiene instructions and have them buy in to cleaning their teeth kind of more routinely and improve their home care. Otherwise, this isn't really going to work, because the same reason why they've lost a bone, you've now introduced something that's going to make it much more difficult for them to clean, okay? The other thing is aesthetics, right? On the lingual of mandibular teeth, probably not a big deal because you can't see it. But if you ever need to splint the anterior teeth and the maxilla, well, sometimes you have to do it from the facial side, not the lingual, and then this doesn't look very good, okay? So there's definitely some compromises to that treatment of splinting teeth. Or you decide to just extract the teeth and then replace the teeth with some sort of prosthetic, okay? All right. So that concludes mutually protected occlusion.